The main reason I'm so interested in Down is I'm specialized in the immune system. And already many, many years ago, when I did my PhD, I chose to do my PhD in the immune system and vaccinations for children with Down syndrome. So hence why I have like a special interest, and I worked quite a bit with children for these type of studies back in the Netherlands, where I'm originally from. This sort of passion has led when I was appointed 8 years ago in Great Ormond Street to ask basically, can I do a syndromic immunodeficiency clinic, which at that point of time actually didn't exist in the UK, but I felt like children with syndromes often are downplayed when it comes to infections or when they have specific issues. The immune system is often not investigated or not highlighted because they say, it's just Down syndrome, or you just it's just slightly different. And I think that is just downplaying, what parents actually tell us and what they actually tell to the doctors and what should be investigated. So hence why I started this syndromic immunodeficiency clinic. And since then, I have seen quite a lot of children being referred from across the UK to sort of do a workup for the immune system. So that's the background. We're going to cover a couple of things today. So, of course, I'm going to tell you something about the immune system, how it works, and what's different in Down syndrome. Then the main thing in younger children is actually related to infections. So I will focus on that. And that is actually not just the immune system. The immune system is just a tiny part of the whole body. So there are lots of other elements that are also really important to be aware of. I would like to focus also on vaccinations, like are they useful? Are there specific recommendations? Are there things you have to look at? I will also highlight that it's not just sometimes that the immune system has a decreased response to when it comes to dealing with infections, but sometimes it also goes a bit overboard, and this can sometimes create the opposite problem. And a lot of people are actually not aware, even doctors, that this can be a specific issue that you need to be aware of in Down syndrome. Then I will tell you a little bit about autoimmunity and screening, which I hope will be almost like well-known knowledge when you go to your local doctor, but I think it's worth it just to mention it once more. And I will briefly sort of mention a little bit of background around malignancy, but that will be just actually one slide. So the immune system, so what is actually different in Down syndrome? So it has actually two sides. So it is immunodeficiency, where the immune system is slightly weaker. It's not like super weak, it's only slightly weaker. And you have something that we call immune dysregulation. This means the immune system is out of balance. It means, for instance, that you can overreact and create issues such as an autoimmune condition or inflammation. If you look at the immune deficiency part, then if you look at children, basically from birth onwards, they have a little bit fewer immune cells in the part that we call the adaptive immune system. So that's like T cells, that's B cells, and they are quite important cells to build up memory against infections, but also to tackle infections such as bacterial infections and viral infections. If you look at, for instance, vaccines, then most children actually make excellent response to vaccinations, but it can sometimes be that they drop their antibody levels over time a bit quicker than other children. And people need to be aware of this, that they sometimes need an additional booster of specific vaccinations to help them a bit better to sort of boost their immune system. And then there are more infections, especially respiratory infections. So upper respiratory or chest infections that tend to appear sort of in the first 6, 7 years of life in children with Down. But every child is really unique. So the degree of like how low the immune cells are or how this then impacts on infections is really, really different per child with Down. And that makes sense because you have like this extra chromosome 21. So you have some extra genetic material, but most of the material is very unique. You inherit it from your parents and everyone is very unique. So you have a little bit extra, but all the other, genetic material that you have is basically your mom and dad come together in you. So what we have found so far, and this is basically like the research has been done in the last, I would say, 40, 50 years in Down syndrome, initially in sort of the 80s and even in the 90s, and even sometimes now when I review an article from other people who are publishing something about Down syndrome and the immune system, people will say, oh, it's just a bit of early aging. So they just age a bit quicker with their immune system sort of getting tired. I have always tried in my articles and in my PhD to say this is not true. They start different from birth. So already when they are born, they have lower T cells, lower B cells. So how can it be that they're already aging if they're just being born? It's just the first day that you are on Earth. Then has to be something intrinsic that is part of Down syndrome. And we actually know this also that even in birth, before you're born as an embryo, as a fetus, you already have seen changes, for instance, in some of the immune system organs as the thymus or other organs. And most of the children, the cells start a bit lower from birth, and then in the first 2 years of life, where you normally have to sort of rapidly grow your repertoire of T cells and B cells to make this little immune system army, then you will see that they actually don't increase their sort of army as much as other children do. So they catch the infections, and normally this would then trigger for your immune system to go a bit sort of overboard and make lots of T cells and B cells. And then you actually boost your immune system. What you see in Down is that they often sort of start low and then they actually stay low throughout their whole life. The good thing is that despite being low in terms of T cells and B cells, the actual protection molecules that they make, these are called the antibodies, they're actually normal throughout life in most children. The vast majority of children with Down, they don't need antibody replacement because they start with normal levels, IgG, IgA, IgM, all these important antibodies. But what we see sometimes with these vaccinations is that they can drop a bit faster their antibody levels than in other children. So I would like to emphasize it's there from birth. And if you feel my child is like catching more infections or it takes longer for my child to clear these infections, you're not seeing something wrong. You're absolutely right. This can happen in Down syndrome. But what the good news is, so I see a lot of children, especially if they have undergone cardiac surgery. So if they had a heart defect that required surgery to correct that heart defect, sometimes they even required a ventilator, so a breathing machine, or sometimes even a heart-lung machine like ECMO. This, of course, impacts on how you're doing so early in life, and you will also likely capture more infections at that moment of time. So sometimes I see then these children to do a full immune system workup. And then what we see over time is that the first sort of 5 years of life, you will have recurrent infections. But then at 6 or 7, all of a sudden, it seems there's sort of light at the end of the tunnel. And lots of children, despite having this sort of little immune system army, will actually be fine with that little army in protecting themselves against most of the infections that are around at that point of time. Well, we have seen a bit when, if you, for instance, your child is born in like sort of COVID times, like 2020, 2021, 2022, most children were like in lockdown and they were not exposed to the normal sort of bugs, like the normal viruses, normal bacteria, because they basically were not exposed to them or they were hardly around because there was only COVID and COVID was like outcompeting every other virus like RSV or flu or any of those other infections that you normally should see in the winter season. So then these children were never exposed to these type of viruses. And then when they were all of a sudden exposed to these viruses when they were 2 or 3, then all of a sudden they become more unwell. And this would be quite worrying because you feel, why is my child now catching these viruses and why are they so frequently unwell? But you were actually playing catch up. Your immune system had to be exposed to these viruses to make an immune response to get stronger. So that has really been like a different season, a different time in comparison to if, for instance, your child is born in like 2024 or 2023, when lots of infections were back in the normal season and you were exposed sort of in a normal fashion to build up your normal immune responses. So the important thing is that vaccine responses are mostly protective and that the children respond really well to the majority of childhood vaccinations. I really rarely see any side effects that are significant to the UK immunization schedule, but I do see a very good response to most of the vaccines that we test in the clinic. So they actually can really make a good response to the vaccines that are offered in the UK schedule. And then the infections tend to improve, but also it's really important that it don't just improve because of the immune system, they also improve because of some of these non-immune factors, which I will talk about a little bit more. And what's also really important, if you would only measure like the lymphocytes and you say, oh, they are low, therefore this child is more at risk for infections or more severe infections, that correlation, that sort of connection is actually not there. We really try to find like a sort of prediction. If you have these amount of cells, then you will be more at risk, but we couldn't find that connection. So even though lots of children have quite low immune cells to start with, over time, they will still improve in most cases, and there's no clear correlation just by measuring only the lymphocyte counts without listening to the actual story and seeing how they actually respond if they are exposed to specific bacteria or viruses. And then if you look at specific infections, so the airway infections, the respiratory infections are really the most common, both the upper and the lower respiratory tract infections. And if you look in the sort of worldwide literature, I have to say most of the literature is like white Caucasian. So there's not a lot of literature, for instance, from Africa or South America, or most of the literature is basically United States, Canada, Europe, basically. But even though there are different healthcare systems, what you see is that if a child with Down syndrome gets admitted for an infection, they tend to stay longer in the hospital, around twice as long as a child without Down syndrome. So it means that catching an infection early and starting that treatment early is relevant, because if you get unwell, it's quite likely you will actually be unwell longer than a child without Down syndrome. This is also why we often advise, if you start antibiotics, to make sure you give antibiotics early enough and also long enough. So not like per se 3 days or 5 days, but it could be 7 days or 10 days in a child with Down. They have also more risk if they catch specific infections such as this RSV or flu or even in the COVID pandemic, that they are more unwell than other children. So for instance, RSV, this is a very classic children sort of virus that is present in almost all countries over the winter time. It causes this bronchiolitis, so it's a respiratory tract infection, and sometimes you will end up on an ICU on a ventilator. And this has been researched quite a bit in Down. Initially, it was said, well, a lot of them will have a heart defect, and if you have a heart defect, you will be also more at risk for RSV. But actually, different groups in the world have also showed that even if you don't have a heart defect, because not all children with Down syndrome will have a heart defect or will have a heart defect that requires a surgical intervention, then still these children, as an independent factor, Down syndrome on itself is a risk factor for more severe RSV, to the point that if you look in the first year of life, we would recommend for children with Down to be protected in that first winter season against RSV. Last year, when I was doing this talk, we had no access, I think, at that point of time to nirsevimab. But since then, this nirsevimab, this monoclonal antibody, has also come on the market in the UK. And this is the sort of alternative from the previous Synagis, a different type of sort of protection against RSV, for which you required every month an injection for like sort of 6 months in a row throughout the winter season. Actually, with nirsevimab, you can have one shot and then you're protected for the sort of next 6 months. It will be really interesting to see if our children with Down then don't fall through the gaps and don't end up on an ICU anyway with RSV, because that data we actually don't have, but I'm actually quite positive that they will be very good in responding to this new monoclonal antibody that is on the market to protect you against RSV. Then for flu, Definitely also leads to a higher risk to become more unwell and require that you need to go to the hospital. It's more in adults than in children that it can be so severe that you don't survive it. That's often not the case in any of these viruses in children. However, I do always recommend for children, well, for any child, but definitely also for children with Down, to get the seasonal flu vaccination every year because they do make a response to the flu vaccine. And especially for the last winter, we had quite a bit of flu across the country, which definitely this year, the seasonal flu jab was protecting against that type of flu strain that was going around. If you look at COVID, COVID is a bit of more difficult because COVID, the first sort of two strains in 2020 and in 2021, were quite severe. So any person, any adult, as we have seen, all seen, and some of us have maybe experienced within our own family members, they can become really severely unwell. Any person with COVID, especially adults. However, if you look at that first two strains, because of course I work in a very specialized hospital, I did see a few children with Down syndrome ending up on ICU, or we were consulted for other children with Down syndrome on an ICU due to COVID infection. And the interesting thing there was actually that it was not per se that they were unable to clear it, but it was more that they were almost going overboard with their response to COVID, and that we had to dampen it down with a little bit of a low dose of steroids to sort of calm down the immune response to COVID in these children. Since then, the COVID strain has calmed down. It has sort of now competed with other viruses and it has become less aggressive, less deadly in the population. You don't see all the hospitals filled up with COVID anymore. So at this moment of time, COVID is sort of competing with any of the other viruses, and that means that if you look at COVID vaccination, I normally tend to sort of look at the risk factors for the individual child, but I'm not blindly saying to all the children you need to have per se the COVID vaccine. Sometimes it's, for instance, useful for the parents to get the COVID vaccine because it might also be useful to protect themselves. But I'm not like blindly always say to all the children you also need the COVID vaccine, but I do recommend the flu vaccination. And then this is an image that I already used like more than 10 years ago, but I think it's still an important image because why do we see more chest infections? And actually, the immune system is only a super, super small factor in all of this. So if you look at the anatomy in this picture, for instance, here, the ear, nose, throat area, then children with Down have a larger tongue. They have often larger tonsils, a smaller throat, and sometimes they also have swallowing difficulties. And then if you go down sort of in this airway, what sometimes you see in younger children is they have this bit of floppy airway. If the floppy airway is above your vocal cords, then you can hear it because then you have this kind of breathing. If you have like the really like intense breathing, but if it's below the vocal cord, you actually can't hear the floppiness, but it definitely can be there. And this makes sort of the airway, the walls a bit weaker. But you outgrow this in most cases. So over time, you will become stronger in this area. But as a baby, this might not be the case. And this means that it's more difficult for you to cough up or to clear any infections that come sort of in your airway. And this is actually a very important factor because your respiratory tract is mainly trying to get sort of bugs out and viruses out before they can even stick deeper into your lungs and create a chest infection. So all these mechanisms, such as swallowing and coughing and having the strength to cough and having a large airway that can also clear up the mucus and the viruses and the bacteria that come into your airway, is actually far more important than the immune system, because the immune system will only kick in if they have no other choice, because they have to defend yourself, because they don't try to create a lot of mess and mucus in your chest, because then you can't really breathe. So your body will not use your immune system early in an infection if they don't need to, because you need to be able to breathe and have this air exchange deeper in your chest. If you have, for instance, a fluid diet as a baby, you will of course have like a milk diet and you lie flat a lot. And then you have, for instance, reflux. Then stomach fluid comes up through your esophagus all the way up, and then it can actually go back into your chest. This can cause aspiration, and aspiration creates a sort of inflammation. So it creates a reaction in your chest for and then it's easier for bacteria and viruses to sort of stick to your airway and to cause an infection. Again, that's not the immune system. That's basically reflux that needs to be treated to avoid aspiration. Then if you have a congenital heart disease, which not all our children have, this also will make you more at risk for creating, for causing chest infections. Some children also have pulmonary hypertension, which also sometimes can sit sort of deeper in the blood vessels in the chest. So sometimes it's underdiagnosed. I also want to say regarding actually this airway shape, the smaller airway, that for instance, if we have to intubate the child because there's a breathing problem and the child needs to be put on a ventilation machine, in essence, we would advise to use a slightly smaller tube than how you would calculate it basically for like age and weight. So, for instance, if you need a tube, 5, we would say maybe use a tube 4.5 instead of 5, so slightly tinier to avoid any damage of the tube being actually too large for a child with Down syndrome. Then the muscle tone, hypotonia, so a lower muscle tone, is also really important because you need to be able to cough up and clear your chest. So working on like with physio and with exercising to make your child stronger is also important. It's not just medication, it's also a lot about these kind of things. And then only a smaller part of all this is the immune system. So these lower cells or the faster decline of those antibodies. So basically improving these kind of non-immune factors are really important and can really make a difference for children when it comes to infections. So what can be improved? So for instance, reflux, to reduce this aspiration, so for fluids to go in an area where there should be air, where you should be able to breathe, is really important. It can be that you need to go to the ENT for review of the tonsils, the adenoids, and the hearing. The hearing, you also have like these sort of smaller connections from your nose to your ears, which is also very well known. It can be that you have to work on more strength, the chest clearance, and the muscle tone. And it's also a lot of children tends to be at a slightly older age with obstructive sleep apnea, and they will wake up quite tired. And this is a very well-known effect in Down syndrome that often also needs to be further tested with sleep studies. Of course, all children should have their heart reviewed because if there's a congenital heart disease present, not everyone needs a surgical intervention, but some might. And a healthy weight, which can be quite challenging actually in teenagers and young adults with Down syndrome. But it really reduces also, how you can breathe and that you have a better strength to breathe. The positive thing is, and this is what most parents actually say, that after sort of the first 6 years of life, they see a significant improvement when it comes to infections. And this also happens because your airway is actually growing and it becomes stronger, your muscle tone improves, your reflux often improves or disappears. And if you have a heart condition, this may be repaired. And especially the heart conditions, if you look back sort of over time in the last sort of 40, 50 years, this has improved. The cardiac surgery has improved so much that, this has really improved the survival in children with Down. So they get through the first sort of year of life having that sort of more complex heart condition corrected. And they can do this now with more advanced techniques than what they could like 40 years ago. And this really has improved the overall survival and quality of life for children with Down. And so all these improvements, what parents are telling me, like my child is actually, fine, is not catching a lot of infections or seems to be tolerating those infections or clearing those infections quicker, happens despite the fact that your lymphocytes remain low. So it mainly shows that although I'm an immunologist and I, of course, would like to emphasize the immune system, but actually there's a lot of other factors that really play an important role other than the immune system. So what we sometimes do in children is giving this sort of preventive low dose antibiotic, which we call, in most cases, we will use azithromycin suspension. This is an antibiotic that you can give 3 days per week. It doesn't really matter which day. Some people do Monday, Wednesday, Friday. Some people do Monday, Tuesday, Wednesday. It doesn't really matter because it sort of works inside the bacteria and it has a knock-on effect for longer than those 3 days. And it's only one dose per day, which is always beneficial because sometimes really hard to do an antibiotic 3 times per day. And what it tries to do is to try to prevent for the child to get a chest infection. It doesn't mean you can't get a viral infection because it's an antibiotic, so it helps against bacteria. But often if you have a viral infection, on top of that, you can have a sort of super infection that goes to your chest, causing a bacterial chest infection. And what we are trying to do with this azithromycin is to prevent those more severe infections, or the frequency, that we can sort of lower the frequency to avoid for you the need to go to hospital or to go to the GP, then ask for an antibiotic. And then once you have the antibiotic, you already feel my child is way too unwell. We're missing again a lot of time in the nursery, in the school, in the development, in the growth. And this is then an alternative approach, which often helps really well. And why it also helps well is because the azithromycin is not just an antibiotic, it also has a bit of an anti-inflammatory effect, which is also beneficial for the lungs. Um, it's not needed for all children. So we always have to make a decision with the parents if it's worth it, and also if we feel it's needed to be used the whole, throughout the whole year. So sometimes if you had a really sort of bad start and you feel my child had a lot of infections and now my child really needs to have some time to be able to develop, to not miss out on this development, and to be able to not have all these infections going in and out of the hospital, and then we stick the child on azithromycin, we then see an improvement. Then sort of in springtime, if the weather hopefully gets better at some point, we will also sort of reassess and say, if the infection season now is actually way lower, there are less viruses around now in the UK, do we need for this child to be on antibiotics throughout the whole year, or is that a bit over the top? And can we actually stop it over spring or over summer, or can we use it like if needed, so that, for instance, you have this powder available, and then if you go on a holiday, you will only sort of mix it up and start it if you feel now my child is unwell, and instead of doing it every week, you will only use it if and when needed. So this is what we tend to do, that in the first instance we try to sort of tip you over the winter so that you don't end up in hospital all the time. And then in springtime we will sort of assess, are we brave enough to stop it, or is your child a little bit too young? Are we continuing it? Or if we stop it and actually it was too early, we can also just restart it. And then in the next season, we will every time re-evaluate it again. Say, okay, now I feel my child is stronger. Okay, let's try to stop this antibiotic, like preventive antibiotic again, and let's just keep it sort of there on the shelf if we need it. And then you will see by the sort of age 6, 7, most children, the parents will say, I really want to stop it. I don't want my child to be on like years of preventive antibiotic, even if it's like 5 or 6 months per year. I actually really would like to stop it and see how my child is doing without, which is completely fair because most children actually are ready to do that. So that's good news, actually. Then, if you look at vaccinations, there's a lot of news on social media and across the globe at the moment around vaccinations. But I would like to say that for like vaccinations for us as like pediatricians, especially if you have been around for more than 20 years like myself, and you have seen, for instance, measles and the effect of measles on the brain and how children end up on ICU. Those are conditions we really actually don't want to see as pediatricians, because we have seen the other side of breakthroughs of or lack of vaccinations. And at this moment in time, we again see a measles outbreak, which basically sits with the lack of herd immunity across sort of the community. So if the vaccine percentage across sort of around you goes down to sort of 90, even 95% sometimes for some of these vaccines, then these diseases can actually reappear and can happen again whereas they should not be in the UK. We should not have measles as an outbreak, but at this moment of time, we do have an outbreak, and we have seen measles again and children with severe measles infection in the brain, unfortunately. So it's really important that if and a lot of parents have missed, some of those preschool vaccinations between 3 and 4 years of age because you were in the middle of COVID or in the middle of a lockdown. You didn't get any message from the GP. Did you get your vaccine? And then a lot of those vaccines have not been caught up, basically, because life happens, and then you actually don't know that your child didn't get that second shot of MMR. But that's really important now, because if other children around your child also are not vaccinated for measles and therefore can actually catch measles, and also your child can catch measles, you can become unwell quite quickly. And they make a good response to measles and mumps and rubella. So yeah, that's a vaccine that I really would like to say, check it. Did your child really get it? And if not, please catch up with your GP to make sure that your child is protected. They make really good responses to those stronger vaccines like tetanus vaccine. Those are all combined vaccines. They also make good response to pneumococcal. We did a tiny study already years ago looking in more detail. They do make a good response, but sometimes over time they drop a bit their antibodies, and sometimes they need an extra booster for pneumococcal. And pneumococcal contains different types of pneumococcal bacteria, sort of like the capsule. So it's not an active like live vaccine, and it protects mainly against those type of pneumococcal bacteria that can cause like meningitis or sepsis. So that's how it's sort of designed, and the UK was actually at the front of that design of those type of vaccines. So they have a really good knowledge around vaccines in general, and a good history in terms of science and background to support the UK immunization schedule. Meningococcal, really important. Slightly reduced response, but still protective. The flu response slightly reduced in comparison to the wider population, but still a very good response. Hepatitis B was one of the first vaccines that was investigated sort of in the 80s when children were still institutionalized, which is hopefully not the case anymore. And that's why at that point of time, some of these children got this hepatitis B vaccine before it was introduced as a sort of standard vaccine. And that's why that first sort of vaccine studies done in Down were mainly focused on hepatitis B, where there is quite a variable sort of historical data of the faster declining antibodies. But what we see now is we see no issues with hepatitis in children with Down. They respond well to these type of vaccines. Then extra vaccinations to consider. So as I said, this RSV. So we have now this newer preventive monoclonal antibody, this nirsevimab, which I think is a really exciting development for children with Down. We're currently working on some vaccination guidelines, but we're sort of finalizing, and we also have asked some parents to read through it and to say how they feel about it. But I would like to sort of synchronize it a little bit also with Ireland and Canada, who are very proactive, I think, when it comes to Down syndrome and vaccinations. So in some countries, for instance, it's not just the first year of life for children with Down to receive RSV protection, but sometimes also in the second year of life. And there's no consensus at this moment of time if you don't have other risk factors. So for instance, if you have ongoing oxygen requirements for chest reasons in the second year of life, you can still be eligible for RSV protection. But if you don't have that because your heart condition has been corrected, your chest is actually okay, and you have Down but nothing else, then you would not be eligible for this RSV protection. But in some countries, you would be. So that's interesting. And time will tell with this new monoclonal antibody how our children are responding to this. And if we also, at some point of time need to revise that sort of advice that is currently out there. Then for flu, I would definitely recommend it because there's definitely a higher risk of complications. The response might not be perfect, but it definitely helps to get the vaccine in. For COVID, we will follow the current sort of UK guidance, but I do sort of discuss this more individual with the parents. Some some children have had like quite severe COVID, and that's why they are also in my clinic to basically follow up on their immune system. But still, the children who had severe COVID in those first sort of 2 years, and those more so sort of severe and strains that we had when COVID sort of started. Since then, the COVID strains have become milder, and even these children that were so unwell that they ended up on a ventilator back then, when you see them in clinic now, they actually seem to manage the ongoing COVID strains much better. So that's actually quite reassuring. And then for pneumococcal, the main reason why I do check that is that we have had a change in our vaccine schedule a couple of years ago in the UK. So in the first year of life, in many countries still, children will receive twice the pneumococcal booster. But this has been changed in the UK a couple of years ago to only one shot of pneumococcal in the first year of life. Then at year, sort of your first birthday, you will get another shot. So instead of two shots in the first year of life, followed by one shot at year one, you only get one shot and then another. So you miss out basically on that second, shot in the first year of life, which is still the case in some other countries. So it can be, therefore, that you have a bit of a quicker decline of your antibodies or not sufficient antibody response, especially, for instance, if you had a heart condition, you had to go to the hospital, you had a surgical intervention, you ended up on a ventilator. At that point of time, your immune system was already working really hard when you already had all kinds of other things happening to your body. And it can mean that, for instance, your vaccines were delayed or were given at a time point where your immune system was not in the best shape. And for those type of children, I do check the antibody levels, and if needed, I will give additional vaccinations. Then there is also HPV. HPV are definitely recommended for children that go to sort of secondary school. It protects against certain cancers, cervical cancer. So yeah, definitely we should give this also to our children with Down. Travel vaccines, if you travel, there's hardly any data about specific travel vaccines. In general, most of these travel vaccines are safe, but some of them are live vaccines, for instance, yellow fever. So if you are if your child, if you're traveling to specific countries where there would be an advice, for instance, for yellow fever, and your child has been really having a lot of infections, then you probably need advice to say, can someone check my child's, immune system, the lymphocytes, the response to vaccines before I actually give this yellow fever vaccine. Most of those other vaccines are actually sort of dead vaccines. They're not like live vaccines, so they're perfectly safe to give. But there are a couple who are live, which includes BCG, the yellow fever, and like the oral typhoid. And if you have really, really low numbers, which hardly happens in Down, then we have to sometimes look individually if live vaccines for children are safe to travel to these countries. So when the immune system overreacts, so this is what I meant. Sometimes you have like slightly lower cells, but sometimes even those slightly lower cells can go a bit overboard. So then they cause an excessive immune response where they actually are going sort of too wild, and they should not do this. They should just clear the infection and then calm down, and then, the whole body can just return to the normal baseline. But this does not always happen in Down. So what we have seen, especially in this COVID, is that they went a bit overboard and they were almost producing too much antibodies and too much white blood cells. And instead of saying, okay, let's stop, guys, we have now cleared this virus, they kept going at it. So we had to then dampen down the immune system a bit, which is quite sort of expert decision making. So it's not an easy decision to make. But since then, also if you look in the literature across sort of the globe, there has been more and more of the other groups that sort of look into Down syndrome. They have also shown that with COVID, some reactions were just over the top. Instead of that they were unable to clear it, they just went over the top with their immune system. And the reason that is actually quite logic, and we were already saying this many years ago, but then we couldn't prove it with our research then. But since then, particularly in the United States, they have looked in more detail why this might happen in Down syndrome. And one of the reasons is the interferon system. So If you have a cell, an immune cell, on the outside of the cell, there are sort of receptors. So they are waiting for signals to be given to them. And once they get the signal on the inside of the cell, a whole sort of cascade of activation happens. And then, for instance, the cell is starting to be activated to be able to kill a virus. What happens in Down? Why is it different? If you look at chromosome 21, and you have this extra chromosome on chromosome 21, there is sort of the genetic material for four out of those six receptors for this interferon system. So four out of the six receptors that are sort of built up from this genetic material come from chromosome 21. So if you have an extra chromosome 21, so extra genetic material for these interferon receptors, you will have an overexpression of those interferon receptors. And it means that if you then get a signal, your signal also will signal sort of harder to the cell because you have a little bit more than other people. And this can then lead to an excessive response, which we also see in some other not related to infection features in Down. You also see it to EBV. So Epstein-Barr virus is a very common virus. It's more like sort of glandular fever. Lots of people have a Pfeiffer Epstein-Barr virus infection, and they actually think it's just a normal cough and cold. Sometimes teenagers have it with these very big tonsils, and then they are tired for months afterwards. So it's a very common virus to have. Most children with Down will be perfectly fine with clearing this specific very common virus, but only very occasionally we see a child that becomes far more unwell than they should when they are trying to clear this virus, and then they really struggle to clear this virus, and it stays around in their immune system, and it really activates the whole immune system to the point that sometimes you have to then say to the immune system, you have to stop and knock out some of those immune cells, for instance, with steroids or other medicine, because they go overboard with this virus. Very rare, but basically what I'm trying to say is, if you have a child and your child is very unwell and they end up in hospital, they are given the right treatment for the infection, but you are in hospital and you have a gut feeling, my child is not responding in the way that I would expect my child to improve. I'm already on days of antibiotics, or I'm already a week on antibiotics, or I'm like really stuck on this ICU. Then it's not inappropriate to ask the doctors, do you think there can be some hyperinflammation? Do you think there can be an excessive response of the immune system that actually makes my child longer, like more unwell, and not really improving on the right appropriate treatment for the infection that you have found? This is not an unreasonable request to ask. And we sometimes get these phone calls, which is perfectly fine, because if you as a parent feel this is not right, this is not how my child normally responds to an infection, then you're right, because it's your child. So these treatments can be challenging. So when to decide and how to decide to calm down the immune system needs a careful judgment, and it's really difficult. We don't always get it right. It may include steroids or other immune modulating treatments, and even then the response can be very unpredictable. So yeah, we need to get involved, but still we don't always get it right. It's very rare, but I would like to mention it. Then autoimmunity. So I hope this is like sort of more well known. Here, it's really good to mention, to highlight that most of this research is done in Western populations, uh, particularly like West Europe. They have done a lot of these investigations. And in some of those Western European countries, celiac disease, like this gluten intolerance, is more common in the population in general. So if you then test it explicitly in Down, but you don't, for instance, test it in other parts of the world, you might be overcalling the presence of celiac disease in children with Down, is what I would like to say. But still, as part of most of the recommendations in most countries across the world, they would recommend sort of to test thyroid disease, celiac disease, and if there are specific complaints, also for type 1 diabetes. Type 1 diabetes we hardly actually see in children with Down syndrome, but if you have like a problem with basically your glucose metabolism, and your glucose is really sky high in your blood, but you can't really get it into the cells and into your body to use it as an energy source, then your child will be super thirsty because the body will try to sort of lower this glucose level in the blood by trying to dilute it with lots of water. So you will be pushed, the signal will be drink water, but then your kidneys will say, we more because we don't need all this 2 liters of water every day. And then still the child will be losing weight because it can't use this glucose as an energy source. And then if it happens and it doesn't resolve because no one picks it up, then in the end there will be this sort of fat that will be burned instead of this glucose, which is your normal energy source in the first instance. And then you will have this sort of smell, ketotic smell, which is basically the same as like nail polish remover. If you know that smell and you smell this, in the from like someone's breath, that is like, okay, that's probably not, the right smell. And you need to see if that's not like the first sign, the first onset of diabetes. But that is very, very rare. What is far more common is more this one on the left is thyroid disease. So it says here up to 50%. It doesn't always mean that these adults need thyroid supplements. It can be that it's just slightly lower and that it's just a bit more stimulated, but it doesn't meet sometimes the threshold to actually start on thyroid supplements. But some children do need thyroid supplements. So if you're having this fatigue, this tiredness, this like temperature, cold fingers, cold feet, which is not always a thyroid problem, because sometimes in children with Down you also see, for instance, different colors of the skin, or if they have slightly lower temperature instead of a fever, or even if they have a fever, they can have a bit of this, skin changes, like patchy changes that sort of sits with that temperature regulation, and doesn't have to be a thyroid problem at all. It's also sometimes something we often see in children with Down anyway, the skin discoloration and the sensitivity in the skin. But we do test the thyroid hormone basically yearly from early in life, and then over time, if there's actually no issue, it's not that often that there will be an issue later. For celiac disease, yeah, you often already, sometimes you have a family history, but sometimes it also just becomes apparent by exposure to gluten in the diet. And then we can just test for it. I don't see it a lot actually here in the UK. I think I saw it a little bit more in the Netherlands, but that's what I'm saying. Like maybe in the Netherlands, it's more there anyway. So that's why more research is needed to really state that these numbers are accurate, or just a reflection of where most of the research is done with regards to autoimmunity in children with Down syndrome. And then if you look at inflammation, so it doesn't have to be specific, as I said, like these viruses, this hyperinflammation. It can also be specific issues like in the skin, in the hair, in the joints. For instance, also we saw that actually in COVID, but also outside of COVID, you can have a bit of like patchy hair loss, or like a bit of sort of brittle hair. You can have these, this happens more in teenagers, so I will also mention it next month in the teenager talk. But hidradenitis suppurativa is often misdiagnosed as like recurrent boils in teenagers with Down. So these are like very painful sort of boils, skin lumps that often sit sort of around your axilla, or in your groin area, or on your sort of buttocks, that often are dismissed as it's probably a staphylococcus, like a bacterial infection. But actually, it's a bit of an inflammatory reaction, and it's called hidradenitis suppurativa, and it really sits on those specific areas where the skin is sort of frictioning, and especially if the hormones are starting to come and you have a bit more sweat and a bit more hair growth, then in those groin areas and the axilla, so in the armpits and on your buttocks, these very painful persistent boils can happen, and it's called hidradenitis suppurativa, and it needs specific treatment, and it's far more prevalent in teenagers and young adults with Down, so like 8 times at least more prevalent. So it's not something to miss as a doctor, but it's not the first time that we get a referral for like recurrent bacterial boils. And then when you see the child in clinic, you feel, okay, but this is hidradenitis. This is a specific skin condition that we see more often in Down. Then like all kinds of different skin conditions, hair conditions can be present in there's a whole spectrum of skin and hair conditions that you can see in Down, but it doesn't need to be the case in your child, of course. Then for rheumatology doctors, it's really important that children with Down can have more like joint inflammation. But they have not sort of mentioned specifically like Down syndrome arthritis because they didn't want to sort of almost jeopardize the research that is being done in Down and also for children if they are, testing new types of treatment for arthritis, that children with Down are excluded from those trials. So they have not made a specific group for children with Down, but rheumatologists should be aware that some treatments don't work as well in children with Down when it comes to arthritis, or that some of the side effects are far more, prevalent for some of those type of treatments than they are in children without Down syndrome. So if your child is started on a treatment for arthritis but has more significant side effects, really highlight this to your rheumatologist because it's probably true. So you might need a slight adaptation or different types of medication in your child. Then neurology, I will talk about this a little bit more in my teenager talk because I would like to mention even this is a talk for younger children that don't have this specific neuroregression, but Down syndrome regression disorder, I think, is quite an important one to mention. We know that adults with Down have an early onset Alzheimer risk. And sort of when you are around 50, 60, a lot of our adults with Down will have elements or full-blown Alzheimer disease. So this is interesting, and this probably also sits with the interplay of the immune system and some of that overreaction of inflammation over time. We don't know yet how to, make sure that they don't get Alzheimer at such an early age. But what we have seen now in the last few years is more awareness for a Down syndrome regression disorder. This is not autism, this is not depression, this is not very early onset Alzheimer in teenager time. This is a specific entity that needs more awareness where your child has been developing completely, according to the line it was developing, going to school, being very sociable, and all of a sudden your child is not, almost like a switch goes off and your child changes in behavior, stops sleeping normally, wakes up in the middle of the night, loses some of the daily skills, becomes either like staring sort of at the ceiling and at the other moment is completely aggressive or behaving in a way that you don't recognize, and it's sort of almost like it happens and you're like, what's happening here? This could be Down syndrome regression disorder. It's very, very rare. So we don't see a lot of these patients at all. And at the moment, we don't have an approved treatment in the UK for these children. But I do want to raise awareness for it because if we do have children or you are aware of children in your community, we do need to raise awareness for this because otherwise we never get to a treatment for those very rare cases where this happens in teenager or sort of young adult age. So basically, if you notice any skin changes, any joint swelling, or any sudden changes, like sort of in this behavior, you need to discuss it with the medical team because we need to see if we can treat it. And then malignancy, I actually don't want to talk about this too much because I am not an oncologist or a hematologist. But I think you know that in the first couple of years of life, children with Down in general have a higher risk for certain blood cancers. So basically leukemias, basically ALL, and also to an extent AML, sort of the first months of life. But overall, over time, so the risk for solid tumors is actually lower in Down syndrome. And also, if you sort of pass that first 4 years of life, then the overall like risk for malignancy is actually not increased in Down syndrome. It's mainly sort of that first couple of years, and after that, we don't see it in that way. So that's important to mention. So mainly the key messages are that the immune system in Down syndrome has two sides. It can be slightly weaker, or it can actually overreact. But every child is really unique. And the chest infections that we see are influenced by a lot of other factors that are beyond the immune system. And many of those other factors, such as like reflux, for instance, they really can be improved. What we also see is that most infections improve after the age of 6, even though like your immune system has still low cell counts. So there has to be other reasons that your child is getting stronger and has less infections. I definitely would recommend to be up to date with the UK vaccination schedule because they make a good response and they don't have a lot of side effects. And you have also these extra vaccinations, such as the RSV protection, the yearly flu vaccine, and the COVID vaccine. The pneumococcal vaccine, I think, especially because we changed slightly this first year, the amount of boosters that we're giving for pneumococcal, I think that will have an impact on children with Down. So it is not unreasonable to check this and see if they need an additional booster. And then also in your local team, you should be having your child checked up for thyroid and celiac disease. This should be sort of standard of care in your local team when your child is seen by the pediatrician. And if you have any specific changes in your skin or in your joints or sudden changes like in the behavior of your child, you also need to speak to your medical team. I will discuss this neuroregression and the teenage health and the transitioning in the following session. So that will be a sort of more like switch over to puberty and teenagers. Yeah, I think I think this is the end of my talk. Yeah. And I just wanted to highlight, this specialized syndromic clinic. I can't sort of accept referrals like from directly from the GP. I only sort of I'm allowed to accept referrals from other like pediatricians and hospitals. Not every child needs to be, seen in this clinic. It only depends a bit on if the local team feels like, okay, this is too much infections, or this it's like so complex, this history. Could you also have a look at the immune system? And often you only are seen a couple of times if the immune system, when I test it, is completely according to the normal Down syndrome lymphocyte count. But sometimes I'm keeping my children a little bit younger just to see longer, just to see how they go over time when they grow.